Hello, this is part 3 of the intro to health psychology. And we left off at why is it so expensive? And we covered that in part 2. All right. Other issues that we've got going on in our healthcare system. We have a physician and a psychologist shortage. To give you a feel for what's going on with the physicians, 2023, the physician shortfall was projected to be between 21,000 and 55,000. A lot of this has to do with aging. These are medical doctors of osteopathic medicine. So when I talk about doctors, that's what you know what I'm talking about. Retiring, burnout from these employees. There were a lot of individuals that did early retirement during COVID. So retired younger than they had anticipated that they would because of COVID. And in some situations, this is why we've got more physician's assistant programs, more nurse practitioner programs, where it's kind of essentially master's level practitioners instead of doctoral level practitioners. Just to give you an idea of how bad the shortage is, outside of metropolitan areas, so outside of cities, there was only 1/3 of the psychiatrists for mental health care. Psychiatrists are medical doctors who mainly do prescription med management. So 1/3 and a half of the supply of psychologists that are needed outside of these metropolitan city areas. We particularly see individuals that are underserved or racial minorities. We've talked about the haves and have-nots. LGBTQ plus individuals tend to be underserved in the healthcare world. And some of that, I know I've got a student who's doing research on this right now. A lot of that has to do with overt discrimination, healthcare providers not willing to see individuals. And then some of that is from the consumer standpoint, individuals who identify as LGBTQ feeling like they've had bad healthcare experiences, feeling like they were not welcomed and well cared for, and then stop accessing healthcare even when they need it. More likely to impact individuals that don't speak English in our culture. And part of the reason why it took us a while in the planning to get our PsyD program and clinical psych in our department was we really had to we made very strong arguments that rural areas are terribly underserved because they do not have clinical psychologists to serve them. As an example, we have a lot of psychologists in Watauga County and in Boone, mainly as a function of the university. Many of the private practitioners who do part-time, like I do in private practice, are on our faculty. And many of the full-time practitioners in private practice were former psychologists at our counseling center at ASU. But when we get out, you start going out to neighboring counties. We've got our faculty in our department taking PsyD students out to Allegheny and Ashe County. That's Dr. J.P. Jameson. And they're serving kids in the school systems. But otherwise, those counties don't have psychologists as providers. And then you get even more rural than that. We've got a lot of counties that have nobody to see. If you're thinking maybe you got ADHD, nobody to see. If you are depressed and suicidal, nobody to see. And so part of the reason why we've developed our program, and part of the reason why we deliberately take strong applicants who are from rural areas who wish to return to rural areas to practice, that's really our mission, is to try to, out here in the rural Western North Carolina, to be able to start producing these PsyDs who can do it all. They can do assessments, testing, diagnoses. They can do therapy. They can work with kids. They can work with elderly. That's really what we need. It's kind of like the primary care and clinical psych. That's really what we need. Oh, back to this. I hope that many of you in here are going to be healthcare providers in the future, because we need good people. We need people out in the field, well-trained, doing what they do. Okay. So I have made the point that our healthcare costs in the US are exorbitant and way beyond our sister countries. It's not any better. We've explained some of the expenses. Why is it so expensive? But now I want to take a look at what have we been doing for cost containment or cost reduction. Okay, trying to bring down healthcare costs in one way or another. One of the more historical ways that we've done that are mental health parity laws. And mental health parity, it used to be that when you had insurance, a lot of the insurance plans, you had access to medical care, but you did not have access to mental health or substance abuse care. Mental health parity laws, North Carolina was actually pretty progressive, and they passed this a long time ago, said if you're an insurance company and your customers are in North Carolina, when you offer medical insurance, you have to offer mental health and substance abuse insurance too. You cannot just say, hey, the body's more important than the mind and mind's unimportant. You can't do that. So that's like a pretty long-term, happened long ago. Kaiser Permanente, I want to talk a little bit about them. We don't have Kaiser Permanente in North Carolina, but they are one of the biggest healthcare providers in California. And they were a health maintenance organization, which meant if you bought their healthcare product, if you were Kaiser Permanente or you were an employee and you bought Kaiser Permanente, that you as the customer could go get any of your healthcare, dentistry, peds care, primary care. You would go to the Kaiser Permanente clinic or hospital and get all of your care for essentially free, meaning you weren't paying copays. Okay. And Kaiser Permanente, because of that, they had to offer, all their customers whatever they needed. They were really interested in, is there a way that we could make it more cost effective so that we can profit and stay a company? They paid attention to when anybody came into their primary care, what were they coming in for? And what they found was that the majority of people coming in for a healthcare visit were suffering intense stress or were suffering from a psychological disorder. And then they were going and accessing medical care when what they should have probably been doing was accessing mental health care. And so they were wasting a lot of medical providers' care on clients that were stressed or had psychological disorders. So what they did is they created this program, and they did random assignment, all that kind of stuff to study it scientifically. When you had woes, whatever, and you went to the Kaiser Permanente clinic, you would first sit down and have a brief session, like a 15-minute session with a health psychologist. And a health psychologist would determine, were you really there? Like if you're coming in complaining of insomnia, that's probably stress related, right? Or if you're coming in complaining of chronic tension headaches, that's probably stress related. Or if you were coming in and complaining of depression, that's stress related and it's a mental health issue. And they would then send people to, well, you need to go to a pain management group. Let me get you hooked up to that. Or you need to go to a stress management group that is focused on headaches. Let me send you to that. They were also the gatekeeper to the healthcare providers. So let's say you go in, you're a customer, you go into the clinic, you sit down with the health psychologist, and they say, why are you in today? And you say, my throat is on fire and my kid had strep last week. They would go, you go see the nurse and let her swab your throat. There's really no need to talk about your life right now. Let's just go and see if you've got strep because you need an antibiotic. They found that the customers of this insurance program, this HMO, loved it because they were getting the health care that they really needed. And what they also found is they saved a tremendous amount of money. And so the company was able to profit. And what they ended up doing was hiring more psychologists with that profit. Another example, Dr. Jody Palaha, she's a friend of mine, and she is in peds over at East Tennessee State University. And she has taken her doctoral students and herself to peds clinics in rural Tennessee. And they practice integrated medicine, and they're there on clinic days where the pediatricians can, let's say peds got mom and kid in their office, and mom says after kid was sick and we gave him cough medicine that helped them sleep for a while, now they're off the cough medicine and I'm having a really hard time getting my kid to bed. That is not a pediatrician's issue. That's a ped psychologist issue. What's going on? Let's say they have dad has a kid in there and says the teacher's complaining, they think my kid has ADHD and maybe a learning disability. That's not a pediatrician's problem. That's a psychologist's problem. What they found that when they were there in clinic, the parents, guardians who brought in their kids very much appreciated, we call it a warm handoff, over to psych peds, and they were able to get the care that they needed. They maybe gave them a whole program on how to help their kids wind down in the evenings and get better sleep. They help with feeding issues, with potty training issues. They're able to do the testing for ADHD and LD, that kind of stuff. And what they found, so the customers really liked it. The kids are getting what they need. The parents were getting what they needed. And what they found is that they could bill for those ped psych services and bring in more revenue to the clinic. But what they also found was the pediatricians and the PAs and the nurse practitioners, they were able to see more medical patients and do more billing when they were seeing the medical patients and moving the psych needs over to ped psych. Okay, so it was win, win, win. The clinics are making more money. The parents are getting what they need. The kids are getting what they need. It's just a really nice example of how integrative medicine works for cost containment. Now, integration into primary care. Most primary care physicians train in family medicine, and that's overseen by the American Academy of Family Physicians. They have integrated in their training in med school, those med students and those family medicine residents train alongside in integrative medicine, psychologists, dietitians, physical therapists, all that kind of stuff. They have integrated more of the health psych stuff into the MCAT, which is the test that they use in a lot of med schools, kind of like SATs or what used to be GREs for psych programs. Because this stuff is more integrated, these questions and this material on the MCAT, that has backed up. You see more courses integrated in bachelor's degrees for people who are pre-health in their training. And as an example, we in psychology, in the Bachelor of Science in Psychology, we now have 2 tracks where individuals can concentrate in natural sciences and health studies or human services, but mainly this would be the pre-PA, PT, OT, pre-med. If they major in psychology instead of majoring in chemistry or biology, get all the requisites that they need for med school or PA school in their concentration, but still majoring in psychology, as an example. And we've got quite a few majors that are doing that nowadays, but we adopted that because we know this is required here, and now more of this integration is required for that. So we're seeing more and more health professionals adopting this more integrative medicine, and in this situation, more the behavioral medicine kind of stuff, into their curriculum and into their training. Now, what has naturally happened in healthcare, and this is quite unfortunate, but there's economics to it. So the natural economic response to healthcare providers is we're asking them to do more and do it faster and do it for less. And part of the consequence of this is data on how many minutes in primary care they spend with a patient. And part of the consequence is they're seeing more and more patients a day to be able to bill more and more money. And then administration in clinics and administration in hospitals are asking the providers to do that, because the more people they can see, the more money they make. However, a lot of the providers really are not liking that. And when asked to decrease the amount of time they spend with their patients, you see these providers, they have less job satisfaction because they're not able to really just spend time, build the relationship, ask the questions, listen, give empathy, all of that kind of stuff. Less job satisfaction, and then a lot more burnout. And that makes sense. Add to that, most medical doctors are spending on average of 16 hours a week on paperwork and administrative duties, which is pulling them away from client care. So if they want to bill the same amount, they got to see more people. If 16 hours a week, they're doing that, or they're adding that, they're doing their, their patient load, and then they're adding all the paperwork and administrative in their own time. It's just a formula for burnout. Add to that, with the shortage here, on average, when patients want to get an office appointment, it takes on average 26 days, which it goes totally against the I'm feeling sick or I just got injured, I need the care right away. And then we get these complications that occur for people where things get worse. They could have been treated earlier, but they're not treated on time. On average, it takes a month to get in to see an OBGYN. Imagine, just as an example, you think you have an STI and you want it treated right away, or imagine you're pregnant and you want to know, is this embryo fetus healthy, because you really want a baby. Flip side of that, imagine you think you're pregnant, or you've had a positive pregnancy test and you've got a medical condition that can't support a pregnancy. Or imagine you're in a place in life as a girl or woman where you absolutely want to terminate a pregnancy, and legally you've got to do that in a certain amount of time. Let's say you were raped, or let's say you're a victim of incest by somebody in your family. That is absolutely critical to getting care immediately and not delayed care. And then what happens for a lot of folks, I know I've had family members who've ended up doing this, where they need to be seen quickly because they've got an acute new illness that needs treating quickly. Then they go to emergency room and get very expensive care in an emergency department, even knowing that they could be seen. I've even had, just as an example, family member who needed family member to be seen in the ER, but during COVID, when a lot of people were sick, knowing that if they went to the ER, they would wait and wait and wait and wait, and they could have driven family member to the ER, call an ambulance instead. Knowing that's going to be more expensive, right? Because now you got an ambulance to pay for as well as an ER doctor, but knowing the ambulance would get the family member in immediately and not have them wait for hours upon hours upon hours in the ER. So we've got, with these problems in our healthcare system, we've got issues that need resolution because it's feeding out more and more problems. Okay. So how can psychology, and another term for this are behavioral health services, how can we make a difference in the healthcare system? So I've let you know how expensive everything is. I've let you know all about the problems. Now I want to start offering up some solutions. Okay. So integrated medicine would be where we're offering up behavioral strategies that are targeting both the medical health, the mental health, the mind, body, the whole person. Okay, the whole person, treating the whole person. But wouldn't it be awesome if these strategies or these interventions where we intervene, these treatments or preventions, wouldn't it be awesome if these saved money? And wouldn't it be awesome if it improved quality of life? I want to camp out here for a second. There are some professionals. Dr. Robert Kaplan is a health psychologist, and after he had his health psych career, went into political consulting. He believes that all outcomes in research should be focusing on quality of life. And he's even got these qualities, which are these metrics of basically when you are happy and healthy, you are incredibly productive. Productive in your job, productive in your home life, taking care of yourself and taking care of others. When you are sick, imagine many of you went down with COVID. When you are sick, you are not productive. You're miserable, but you're not your normal self, taking care of all the normal stuff that you take care of. When you are dead, you are engaging in absolutely zero behavior. Okay. You have no quality of life because you're dead. You can't do anything. Okay. And so they really are focused on in medicine research and behavioral sciences research, we should all be looking to not only are we curing or managing a health condition, are we improving that person's quality of life? That should be the outcome. Okay. To get a real feel for integrative medicine, I want you to watch the New Medicine documentary. It's 114 minutes long. Pay attention to the champions. Many of the champions featured in this are medical doctors first, and they have sort of seen the light and found integrative medicine and are championing it and doing it and trying to spread the word. You will also see some psychologists that are featured in the documentary. Pay attention to the cases. There's some really interesting cases in the documentary. And then after you watch it, let me know if you've got any questions, any comments, and we will take care of that. Okay. This is a bit of a dated article, and I've looked recently and I've added even some articles on As You Learn for us to read. I've added some more up-to-date articles in my lecture in here. But I really like how Friedman et al. In their health psychology publication took these integrative medicine interventions that we do and put them into 6 pathways because it's easy to understand the names of these pathways. It's easy to memorize them. I will ask that you do that because I think this stuff is so important. And these are pathways where psychologists are doing behavioral health services or integrative medicine. And in a lot of cases, other allied health professionals are doing these types of interventions too. All of these improve quality of life in patients. That's a win. All of these reduce costs. That's a win in our expensive healthcare system. And all of these target demand for healthcare. So they're targeting the consumer of healthcare and allowing them to have better quality of life so that they don't need to be using so much healthcare. Keep in mind, most attempts at healthcare cost containment have targeted supply. So targeting supply would mean something like, okay, you've got this kind of leukemia. We will pay as your insurance company for this kind of chemotherapy, but we won't pay for a bone marrow transplant. Another example would be something like you've got a skin condition that is causing you a lot of pain. We, as your insurance company, we will pay for that treatment. You've got a skin condition like acne that is more cosmetic and problematic. Insurance company could say, we're not going to pay for that. We're definitely not going to pay for Botox because you think you need, to numb your eyebrows or whatever because you're aging. So most of those things have targeted supply, but here we're going to target demand. So the presence of behavioral health services in primary care, let's take a look at this comparison study here. These are patients with diagnosable psychological disorders. When they were given behavioral health services in primary care, they reduced their medical costs by 17%. On the other hand, in the same study, and they've got random assignment going on here, same types of patients with psychological disorders, they were not given the warm handoff. They were not given behavioral health services by psychologists. They had an increase in their medical costs by 12%. Okay. You see dramatic cost savings here by adding the behavioral health services into the primary care setting. And what the behavioral health consultants do. They do a lot of crisis intervention. Let's say you got somebody in the office who is crying, suicidal, and depressed. They're going to get in there and intervene and do safety planning for that individual. Sometimes that involves hospitalizing them, but a lot of times it involves counseling against access to lethal means, other safety planning on helping people develop strategies for coping when they're really bad. They might do psychiatric consulting. Let's say you got primary care doctor thinking, I'd like to give an SSRI to this client for depression, and they could be consulted for that. They do brief psychotherapy. They do a lot of relaxation training, meditation training. They might do biofeedback, which is when you're using devices to train people into a meditative, relaxed state. We're going to talk a lot more about that kind of stuff when we talk about stress management. And then they do a lot of psychoeducation. So let's say that you've got somebody with type 1 diabetes and they're not injecting their insulin. They have no idea what's gone wrong with their body and what diabetes means. And they're not injecting their insulin, maybe because it's expensive and they only inject it when they have to go out during a day, but they're not injecting it when they're staying at home. Psychoeducation and helping them understand that your body can't burn its fuel, the food that you eat, unless you have insulin. Insulin, imagine the food are like logs, but you can't burn a log without fire starter. The insulin's the fire starter. You can't get heat out of that log without the fire, which is the insulin. Things like that. So psychoed about what's going on with them would be something that a psychologist would do in behavioral health services. So integrative care, this can be very helpful with, especially helpful with ethnic minority groups. So it's actually a way, having these behavioral health services and integrative care is a method of helping to eliminate health disparities. We know that low socioeconomic status patients have more behavioral health needs. It's a way of reaching the people that really need it. And then I want to show you an example of a really brief consult. So let me get that link. Oops. Okay. Okay. This is just an example, really quick and dirty consult here.
Really appreciate you being willing to sit around and chat for a little bit. I'm one of the other team members of your primary care team, and I'm a behavioral health consultant and a licensed psychologist. And my goal is try to work as closely with the medical providers as possible. I document in your medical chart as well, and just try to help people improve health in any way possible. And that means working with people on physical health things, such as trying to improve diet, sleep, exercise, and also if there's any kind of emotional things going on, stress, anxiety, depression, we look at the whole person for that. So we'll chat for about 15 to 20 minutes today. I'll get a good snapshot of what's going on currently, and then we'll kind of work together as a team to come up with a good game plan to address anything that you think would be good to address. Some people get what they need out of one visit. Other people come back for follow-up appointments. It's like coming to see your primary care doctor as things come up. You see us more often. As things get better, you see us as needed for that. And then after we get done chatting, I'll check back in with Dr. Elwood and let him know what we kind of discussed and what we're going to work on. Sound okay? Yeah, that sounds good. All right. Jesse, I really appreciate you.
Okay, let's get back to the PowerPoint. That's an example of a good little elevator speech spiel to be given to a patient. Keep in mind after that, he's going to do a lot more asking questions and a lot more active listening kinds of stuff. But you're not necessarily seeing that right there. But just an example of an introduction kind of thing. Okay, so an example of behavioral health services and integrative care. Okay, I want to talk about types of integrative care. Coordinated care in behavioral health services would be, we've got level 1, level 2. Level 1 would be there's some collaboration in primary care, and the behavioral health person, usually the psychologist, and they might refer to each other and view each other as resources, but there's really not a whole lot of, they're not in the same place, and they might communicate with one another occasionally about a patient or a client. Co-located care is where you've got the mental health care and maybe some of the behavioral services in the same place, but they're not necessarily, the professionals aren't meeting together. They're not talking, bumping into each other and talking very much about their patients that they're both seeing. In integrative care, I want to focus on these a little more specifically. There's level 5 and level 6. 5 is collaboration strong with primary and behavioral healthcare providers working as a team. They're communicating frequently. Their respective roles are clearly defined, and the practice structure is modified as needed to meet patient goals. At level 6, there's full collaboration with a single healthcare system devoted to treating the whole person, is applied to all patients and not just targeted groups. So this 6 would be ideal. Just as an example, we have a federally qualified health home here in Boone, and it would fit a little bit more into like the co-located level 3 and level 4, but not quite up to level 6. Okay, so I promised you 6 pathways. So this is going to be pathway number 1, information and decision support. In this example, is assuming that, well, we know people make their decisions to access healthcare based on a lot of things other than just good information or education level. One example would be fever. So you got these new parents, they bring home a baby, and we know that fever is actually a natural reaction to a pathogen. It builds up the baby's immunity. It's usually a good thing. We also know that fevers are higher in a viral infection than they are in a bacterial infection. There's not a whole lot pediatricians can do to a viral infection. We also know that you can give a baby Motrin, and I can tell you from experience, it's amazing. You put Motrin in a bottle with either, the baby's formula or juice or something like that, and you hold that baby and give them that bottle, you feel that fever drop. It is just amazingly effective. Also, to know that fever is a normal natural response. It's the body raising its temperature, because a lot of the pathogens that cause infection and a fever can't live in a higher temperature. So it's, it's all functional. I knew when my babies were born that fever, how to self-treat it, and when to wait and see if like they develop like a secondary infection, and when to take them in to see a pediatrician. But a lot of parents don't know that information, and they think every single time a child has a fever, they need to go to the pediatrician, or if it's nighttime or weekend, they need to go to the ER. And that is unnecessary care. Okay. But a lot of people don't know that. They don't have the information that they need to make that decision. And of course, the fear of like, oh my gosh, what if my baby dies on me because I don't go get them health care that they need? Yeah, that's a pretty powerful fear. It makes sense to me. So a lot of people do that. They over get medical care out of a very reasonable fear, but they don't have the information that they need. In this particular study, what they did is they randomly assigned new parents in their insurance plan. Some of them got nothing, and they all could go to healthcare as needed. But some of them were given a telephone number where they could call 24/7 and speak with a trained nurse, and say, here's what's going on with my baby. Do I need to take them to the ER? And in a lot of situations, like a fever, they would say, okay, how high is the fever? Okay. Do you have liquid Motrin where you can give the baby Motrin in their mouth and put it in a bottle? And then they would, do things like, and if this doesn't improve 2 days from now, then you probably need to see your pediatrician or whatever. And what they found is that parents loved it. I would have loved to have something like that when my babies were little too, just to call up and just sort of say, hey, we got this going on. What can I do to self-treat? What, do I need to take them in? That kind of thing. They found that it cost $1 per person to deliver this intervention, and that was to staff people on the phone line. And it ended up saving this insurance program $2.50 per person when they had the counseling phone line. Again, because they're not accessing unnecessary healthcare. That's where the savings occurs. Okay. So the idea, if you give people the right information and you help support their decisions, they will not over access healthcare. Okay. The psychophysiological pathway, this is just a really fancy word that means stress makes us sick. Okay. And I'm not going to go into this in detail right now because I've got a whole lecture series on stress and coping that's going to be coming up in this class. So I'm just going to skip that. But if stress causes illness, wouldn't it make sense we'd be treating stress so that people don't get, mental health issues? Wouldn't it make sense that we treat stress so that people are not getting physically sick from their stress? Yes, it does make sense. In this one particular study, I want to give you one example of this and how it might work. They took these medical patients and they randomly assigned them. Everybody got access to their health care as usual. They randomly assigned them. Half of them got a stress management program where they learned how to manage their stress more effectively. The others did not get the stress management program. And then what they measured, they followed them up a year after that, and they measured how frequently they went to their medical care provider primary care office. Okay. And what they found is that the people that got the stress management program decreased their office visits by 70%. Okay. That was huge. They're feeling better. They're less stressed. They're feeling better. There's no need to go to the doctor. But here's where it gets interesting. So these people did not get the stress management program, but they knew that they were enrolled. They were all enrolled in a study. Okay. And I can tell you, if we ran a chi-square on this study, the difference between 70% and 26%, is it statistically significant? Oh my gosh, yes. This is a huge effect size. Huge. Okay. So tremendous cost savings over here. But I want to camp out for a second because there's an important thing going on down here. All of these people knew that they were enrolled in a study. They signed a consent form. They met with, a research assistant. They knew that the study was approved by a human subjects committee, like an IRB, but they got nothing special. They still had a decline in their office visits. You would have thought this would be equal to 0%, right? But it wasn't. They had a decline too. If I had you live in class, I would say, what do you think's going on here? But I don't have you to answer. So I'm going to tell you some of the stuff that I think is going on here. This is a placebo effect. And we're going to talk more about placebo throughout the semester. And instead of thinking about placebo as being this nuisance effect that you have to control for in our science, which we do, I want you all to leave this class knowing we need to harness placebo. Placebo is really powerful, and there are ways that we can ethically harness it and use it. And I'll give you an example. So let's say I had a client come into my office. I sit and meet with them for an hour. I ask questions, I listen, and their diagnosis is panic disorder. Okay. I could say, you've got panic disorder. Do you want to make another appointment? And in that situation, I would not have delivered any placebo whatsoever. I'd be like, this is a panic disorder. Would you like another appointment? We'll start treating you the next appointment. If I offered placebo on top of that, I would spend that time with that person, ask questions, be empathetic, all that kind of stuff. And at the end, I would say, hey, looks like you've got panic disorder. Okay. Panic disorder is gnarly for people who had it. I've had panic attacks before in my past. It never developed into panic disorder because I knew what it was. I knew it was a panic attack. I feel for you. The good news, however, is as a psychologist, I've got some really great treatments for panic disorder that are very effective. We're going to do some CBT, we're going to do some ACT, some ACT. As we go, I'll tell you very specifically, why we're doing what we're doing and how and why it works. But I can guarantee you that pretty soon we're going to get these panic attacks under control and you're going to be feeling better. Okay. I didn't have to offer all that hope. Okay. But it's psychoeducation, it's offering the hope, it's placebo, and I'm doing it ethically. I'm actually doing it very responsibly, but I'm doing it ethically because that's what the science says our treatments for panic disorder do. They really work. Okay. Now, in this situation, they may have also, it's the altruism piece that we're going to hear about in Walsh's TLCs. They're doing this good thing. I'm this good person. I signed up for this study as a guinea pig, as a participant, because I believe in science and I want to be helpful to other people in need. Another thing that was happening is you've got these really nice research assistants meeting with these individuals, having them go over the informed consent, sign the informed consent. And research assistants are trained usually to just be really kind and really nice. Thank you, Mr. Smith, for signing up for this study. Man, it's really cold out there. How you dealing with this snow and this wind? Come on in. You can keep your coat on for a while if you want to, but let me know. I can help you hang it up. Have a seat and let's go over the paperwork. Kindness. Ellen says this. Ellen DeGeneres, who I love. She would say this at the end of her show every day. She would say, be kind to one another. And it's like somewhere in this, and we're gonna have a whole lecture on social support and what healthcare providers can do to listen better to their clients and understand them, what they can do to motivational interviewing, how to interview them in a way that starts to create behavior change, that kind of thing. But the kindness and the warmth and the listening and showing you're listening, all of that is really, really important. Those are interventions in and of themselves, separate from a formal intervention like CBT, separate from giving somebody a pill. This can be really powerful, but I just wanted you to understand why there's such a difference in this effect. All righty, we're going to call it a day for part 3 of the intro lecture, and we will pick back up here in part 4. Bye.